suspect. Okay, so contour. You know, there's scaphoid, which is someone who like hasn't eaten, you know, is starving. Just right by your, there you go. So like someone who hasn't eaten is like starved. Like when you see, it actually goes down like those supermodels that are anorexic looking. But that may not necessarily be a sign of starvation, right? You see the babies who have the different eating disorders with the extended bellies because they don't have enough protein. Or, yeah, okay. But people who do and are just starving themselves, they often have a scaphoid. Then there's flat, and then there's rounded and obtunded. I would have a obtunded belly. So, Rayan, right? Rayan, I would call that flat. Does everyone agree? Yep, flat. Contour is flat. Does it look symmetrical? Do we see like any bulging of where the liver is or anything else? Any masses sticking out? So it's symmetrical. Her skin color, I would say, is a peach. It's not. We need to come up with a better. What the heck is white skin?
Olive skin, you can say.
I think of olive as like black.
Oh, no, olive skin is like tan.
Green.
That's what I think.
She's not.
No, but they say olive skin people like people with like a darker
Mediterranean,
skin, like a
yeah.
little bit darker, yeah.
A little bit darker. So let's-
tan, I don't know.
Okay, let's say she's a,
Yeah.
I don't know, light tan.
Peachy.
In color. And her skin, do we see any scars? Well,
No.
I see a little bitty where she probably had an umbilical piercing. So, and you can see the other side there. It's just not there now. And it's not inflamed. If you see them, it's not a big deal. It's just like you might just want to say whether it's not inflamed or anything like that. Because they can get, you know, infected. And the other thing is pulsation. Now, remember how it was hard to see the pulsation for the apical impulse? I'm going to have you put your feet side by side, okay? These ones are easier to see. What I'll do is have her do the deep breathing, though, to help you see it better. So you take a deep breath in, and then hold it all the way out. Hold it all the way out, and you'll see it right in this area. You guys see it?
Mm-hmm.
It's right in here. Breathe if you need to, honey. Okay. Deep breath. Let it out. Let it out.
Mm-hmm.
It's it's just a slow pulsation, and you can do the trick with the light too if you need to. And so it's the aortic pulse. It's the aorta. That's the aortic pulsation. Okay, and if we see it, just like if we see the apical impulse, we have to say where it is, and we see it midline in the epigastric region. Right? It's not way over here. It's not way over here, and it's probably only about a centimeter. It's not pulsating all the way out here. Right? It's only about a centimeter in pulsation, maybe, or centimeter and a half. Does that make sense? All right. Because if it was way out here, what might we suspect? An aneurysm, yeah. Okay. And why are those bad? Because they're weaker walls, and yeah, they can burst easy. And that person can be dead within seconds. Because it's a big.
That's from it being blocked, right? The vessel's blocked.
No, the aneurysm.
It explodes.
It basically outpouches like with diverticulitis, but it's a weaker wall.
Dissection.
It can happen with more pressure,
Okay,
like
with
if you
dissection.
have hypertension or. Okay.
Can I ask you something, Jean?
Yeah.
Do you know what the difference is between an aortic aneurysm and an aortic dissection?
Dissection, I think, would just be a split.
Yeah, so it's
Aneurysm
ripping.
is the actual aneurysm.
Okay.
I guess it can. If it splits, it can be a dissection. You can have an aneurysm that's not, split. Dissection. Dissect. It means it's cut.
Yeah. That's what I was
So I don't. Maybe once it splits, it's a dissection.
Yeah.
All right. So we've looked at all that stuff. Does anyone have this? Can I blow your stethoscope, honey? Thanks. So then we're going to listen. And the reason why you do it in this way, which is different than the other, the cardiac and other exams, is because of you don't want to disturb the sounds. You want to listen to them first, okay? Although you will see people do that all the time. All right, so you want to listen where first?
Upright.
Right, lower. Because,
All right, lower.
And why
That's
is
right.
that? you're more likely to hear them there. Yeah, more sense. Okay. So this is going to be with the diaphragm. This is where you can put pressure down. So, and normally this would be to here, okay? So I'm going to listen.
So if she's having pain and she already here in the middle of the like before
And as soon as you hear the sound, move on.
You don't do it for a whole minute.
No, not unless you don't, if you don't hear anything, you wait for a full minute, but once you hear it.
She said,
What?
she said, no, she said like after surgery,
Doesn't really matter, but if she says that way, that's fine.
like after surgery, after anesthesia,
Oh, okay.
that's when you do it because they're more likely don't have peristalsis going on. So
Yeah. If you go this way during the exam, I won't fault you, because I mean, I do that. So, but I guess Dr. Roberts said to go this way. All right, so go that way. All right, so you make your clock, you go clockwise, I guess. Yep. But you start lower first. And sometimes they're hard to hear, especially when it gets noisy and you guys are all talking. You may have to like even, you know, go out there or somewhere really quiet to hear. And it's not, it's just gonna be like, they're like really soft usually, unless they're really hungry or they've just eaten. Does it, anyone, you know, it kind of sounds like when it gurgles in your own belly. Okay, so we listened, and that's with the diaphragm. Now with the bell, which is what we don't push down hard, we're gonna listen over the aorta. So over the aorta. And basically you're listening for breathes, which are abnormal. You shouldn't hear them. And that's and then the renal, which, I mean, if you're looking at this, they're like right here.
So just follow
And again, see, I'm not leaving an indentation. Okay, and then iliac. And then you don't have to do the femoral.
right under the ribs you're following.
I am. I'm going right here. See, here's the zoop, here, here, here. And if you look at the picture, that's exactly like it is. And then here, here. And then we're gonna percuss. Remember percussion? Okay. And first you're just gonna percuss just the quadrants in general. Then we're gonna specifically do the liver. Okay. So usually to make sure you get every area, you do a zigzag. And I kind of divide the belly up into 3. And this sound is called, are you the only one that knows? Tympanic, right? Compared to, what's this one?
resonant.
Resonant. You hear the difference?
It's like more hollow.
This is more hollow, yeah. Okay, because that's more air in there. Sometimes it's because there's more air here. Sorry. Hear the difference? Still air, but a little bit, the gastric bubbles there. Okay. So for the, you know, it's all tympanic that I'm hearing. I had a student who had a kidney transplant. It was right here. So what do you think we heard here?
Flat.
Dullness, yeah. Yep. Okay, so then we're gonna do the liver. Okay, so usually you look at the midclavicular line, or like the right, like half. You divide it in half, and you come down to about here. Okay, this is where you want to go up. You don't want to start over here. You want to start over here. And if you feel the rib cage, I'm starting like maybe 2 fingers from the rib cage. Tell me when you can hear a change.
There.
Mhm.
Right there. Tell me when you can hear the change again. So she's probably about right, if I marked it here to here, which is about normal for a woman. It tells you the normals for women and men on that sheet. Do you see it?
6 to 12, she said
Yeah.
today. Yeah.
Good.
Well, it's 7 for
So if we did it on Jesse, Jesse would probably be a lot bigger because he's taller and because he's a guy. All right, so that's, want me to do it one more time? Are you guys okay with that?
Got it?
You're okay, all right. So then the next thing I'm gonna do is palpate first light, and we're looking for guarding, which I'll show you after, I'll have someone do it on me and I'll show you what it looks like. Rebound, tenderness, and masses. So you can say, you know, let me know if it hurts anywhere. I wouldn't make a big deal about the because some people will say it hurts everywhere. And there are tricks to, oh, it hurts, it hurts. You know, it's like, okay. So just let me know if it hurts you, and you're just gonna go light. Some people are very ticklish, so sometimes if you try to do this and you're not getting anywhere, you can pretend you're listening again and say, oh, okay, I'm sorry you're ticklish, and just now you're going like this more because they think you're, you know. Or you can have them use, you put their hand on top like this because they're less ticklish to themselves, just to get them used to it and then try. So for now we're doing light. And why would we do light?
Well, if it's tender, then you want to start light and then move on to like deeper.
Yeah, what if they
so.
have their whole abdomen is like infected? Then you're gonna put them in a lot of pain.
Right.
Right. Okay, and sometimes like if you know, it's just muscular pain versus deeper pain. Okay, so we did it light and you kind of do in a circular motion. Now we're gonna go a little bit deeper. Unless you have to press down a few centimeters more. And you really shouldn't feel anything. Now, if her liver was expanded, you would feel it here. Like if someone has mono, I have felt livers and spleens that are down there, but it should just be soft in these areas. Okay, so suppose, let's say she has appendicitis. I mean, they're an inflamed appendix, right? So what we want to do is see how bad it is when they say an acute abdomen. That means the whole abdomen, the peritoneum is inflamed, okay? And that's another reason why you wouldn't start going bam, 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 okay? So there's two ways of doing this. Like that, Nathan. Some people do it like right on top of the area that hurts and says, does it hurt worse when you push now? Or did I go? And meanwhile the person's dying because you're pushing on. I don't like to do that. I like to do it a little place away. Because really what you're trying to do is just move the peritoneum. Okay, tell me if it hurts. I'm going to let go, because then you're, boom, you're moving it. I mean, actually, if the person can do jumping jacks, they don't have an acute abdomen. Right? Because, you know, if they can hop off the bed. One of my students said that her appendix was inflamed, and all the residents were going by jostling the bed to see if it would elicit the response. Okay, so she didn't have any masses. Now let me show you what. I'm gonna have you get up to me, and let's pretend you examine me. Just feel like you're feeling my belly, okay? Okay.
What am I doing?
You just pretending to feel my belly. Hold on, okay, and I'm just gonna show you guys like what,
So just like
yeah, what guarding would look like. So let's say right here on tender. Oh, that's exactly what it would look like. They'd come up, flinch, and move
Like
their
walking.
hands down. Move their hands down to protect. All right, we'll do that again.
okay,
Just go a little bit slower this time. And they don't have control. I am obviously,
Right.
but they don't have, it's like automatic, like, oh, no. Or like, you know, if your ankle is sprained and someone starts, you pull your ankle away. It's like, oh, no. That's kind of like a guarding thing too.
Would it feel differently, or
It hurts.
well, like for you, like when you're
For me?
touching it, would it be harder, or
No, it may not. It may not. It's just that it's so tender for them. Kind of like the straight leg raise. If someone really has sciatica, they're not going to let you do that. That's kind of like or if someone goes, boom, you blink your eye. It's kind of like an instinctive reflex. Okay, any questions, folks?